The issue has been increasingly, how do you get it? And where do you get it from? And we think increasingly about a sort of an approach to this which is sort of tiered, that there are going to be a few therapists around who increasingly, it's certainly an area that's developing in the UK, but by no means available everywhere yet, who can provide a sort of CBT therapy which involves sort of regular sessions. Usually it's going to be psychologists or nurse therapists offering this, sometimes psychiatrists, but usually psychologists and nurse therapists. And what we're aiming at is that mental health staff generally are able to provide these sorts of interventions in at least brief forms. And a particular study we've been involved with has shown that can be very effective and something which endures as well, which lasts over a number of years. So that's an important approach. And that everybody in services now understands that this is an approach which is helpful to very many people and really should be made available for them. We're therefore training people in various ways. There's a diploma locally that we have in Southampton. There's also one being set up in Institute of Psychiatry in London, and others, other services which also have training which provides some of this sort of training for this intervention. Clinical psychologists are increasingly getting this sort of training. There are courses which have been called thorn courses in the past, but courses which provide people with, nurses particularly, sometimes OTs, social workers, with a broad basis in cognitive therapy, family work and case management. And we've also had a sort of insight training package that we've had available over time and just getting available again. And basic sort of day workshop. So that's the sort of training that's available for people. There's been a problem with getting the money to get people on these trainings recently. That's been a key issue, one that we're very concerned about. The training's there, and quite often these training courses aren't full, and they should be, because this sort of intervention should be available for anyone. One key thing is that people who receive any of this sort of training get supervision and continue to have supervision, which really just means meeting with people who've got a little bit more experience, sometimes people with equal amounts of experience, just so that they can keep working, because sometimes people are trained and then gone back into practice and not used the skills, which has been a terrible waste. And then we have teams who can offer this sort of intervention in outpatients, in inpatients, and again increasingly that's becoming available, helping people understand what CBT is, providing sessions as time goes on as well, which help boost this as well. So although we offer sort of maybe 20 sessions, this is a problem which can come back. Therefore, having people around to work with it. I mean, we use medication to try and maintain progress. Having booster sessions occasionally can be useful as well, and we're increasingly training psychiatrists to be able to offer that. And thorn therapists and others to provide this sort of basic training as well, along with expert therapists who can offer people with more complex problems, maybe with drug and alcohol problems which complicate this. There are ways of working with that group as well. Now, getting it involves, first of all, having some information. So I'm delighted you're here today, and I'm delighted this DVD is being made, because that can provide some information about what it is and what it's there for. And that RETHINK have information on the websites, what psychiatrists do. There are various books around. One of the key things is checking, first of all, that whoever might benefit from it actually wants it, but that involves an understanding of what it is. And what it is really is just sitting down and talking with somebody who wants to understand what's happening, what's going on, and why the person has the issues that they have. And that then should be followed really by talking with whoever the people involved with the person's care are, the consultant, the care coordinator. And yes, not suitable, not available comes up all too frequently. Not suitable, I think we're concerned here in this use before somebody's had an assessment by somebody who knows about CBT. And so we would be tending to say, okay, well, let's at least check out that somebody who has experience of CBT has seen the person and made an appropriate assessment, or at least had appropriate information, be sure about that. Okay, maybe the person doesn't want it, As I say, we found that to be unusual, and often people later on will say, okay, yes, I'm prepared to go and have a chat about it and see if I can understand things better, even if it's just to get that psychiatrist on my back. I mean, it may be also, whoever else on my back. Those may be reasons. The idea that it might upset them, I think, that looks very much less likely. That most of the research that we found sees the CBT far from being upsetting, actually allows the person to talk about what's important to them. They haven't got the appropriate problems, well, I think that would be pretty unusual. They lack insight. Well, again, as long as they'll go and talk, it's amazing what engagement can happen. They won't respond to it, but at least try and see, first of all. Give it a chance. And the NICE guidelines, which I mentioned earlier, which are available on the web, and which all mental health services know about, are reasonable to refer to and say, well, actually, they're there, and they say everybody, as we mentioned earlier on. And they should be available, and that it's reasonable to have an assessment. Not available? Well, okay, how is the trust intending to meet NICE guidelines? If it's not available, what are they doing about it? There are training schemes around. Have they got people going on the training schemes? In fact, quite often, people on the training schemes will be getting the sort of supervision that allows them to work with people with quite difficult problems at times. So that can start very quickly. As soon as someone gets on the training scheme, they're going to want people to work with. And that can be a very, very beneficial way of getting initial help. How many trained therapists do they have already? Because quite often trusts have therapists in place, but they're just not using them. People who've been trained, but who are not, at the moment, perhaps being facilitated to provide the support they could do. How many are being trained? Can they see whoever it is that might benefit? There are books around. There's two that we've been involved with. Those are sort of more technical books, but we think they're reasonably accessible. There are also a couple of books now around which are available, which are specifically focused on users and carers. And these two, Andrew Gumley's Staying Well After Psychosis, and this one's just out by some people from London, Freemans and Garrity, Overcoming Paranoid Thoughts and Learning to Trust, are just out, and that sort of information can actually be very valuable. Okay, I've talked for more than long enough. Would you like to, if there are any sort of questions that come out, any comments?